we can. So today's lectures start with breast pathology. So I have sent the presentation yesterday. So it is not a large presentation because it is just one organ. So in some books, you'll see that breast diseases are discussed among female genital systems. In other books, it is a separate chapter and so on. And here we have it as a separate chapter, and this is what you saw in this book, Fundamentals of Pathology, and most of other books also. This is a separate chapter because not only females have disease of the breast, there are males who have diseases of the breast as well. So the anatomy of the breast, and you remember in embryology that breast is actually a derivative of the skin. So it shares some features of the skin, although of course it has specialized glands which make milk. So the glands are organized into lobules, and the milk will be excreted through the tubules or ducts. And that's why we see that the diseases of the breast are mainly, of course, epithelial, from epithelial cells, and either from lobules or ducts. And a few diseases are from the stroma, which is fibrous and also with some fat. So below the breast or behind the breast, we have the muscles, and we have also the leaves as bones. So the other parts, the main parts of the breast, there is the breast itself, but it has the nipple and the areola. So the nipple, you know, it is the one the baby uses to suck the milk. But around it, we have an area which is usually brownish, and this is areola. So this area is very sensitive, the nipple and the areola. So, for example, when you have to do a procedure using needles in the breast for the breast regions, when the region is quite behind the nipple, we don't do it. Or when it is behind the nipple or the areola, we try to go not from this area because it is very, very painful. So we go through a area. When it is not possible to reach here with needles through this way, then we do just a surgery under anesthesia. So this is the histology of the breast, and we can see the ducts here and the smaller ducts here and lobules. So as I said, the breast is modified sweat glands that, you know, they are parts of the skin, derived from the skin. So the breast tissue can develop anywhere along the milk line, which runs from axilla up to the vulva. So that's why you will see some people who have spannumerary nipples, so looking like a breast at any area. So usually what we saw personally, so they are just nipples toward the axilla, but not toward the abdomen. The terminal duct lobular unit is the functional unit of the breast, which is shown here. So the terminal duct lobular unit, it means here you have a central duct, then you have lobules here around. So this is called the terminal duct lobular unit. Lobules make milk that drains via the ducts up to the nipple. So lobules and the ducts are lined by two layers of epithelium who have luminous cells. These are inner cell layer lining the ducts and the lobules, responsible for milk production in the lobules. And behind them, we have my epithelial or cell layer. I think I mentioned this when we saw prostate. So prostate is also the same. We have in the glands, we have secretory cells, but behind them we have small cells which are called the myopithelial cells or basal cells. So their role is to contract, to do contractions. When they contract, then they propel milk towards the nipple. So for prostate, when they contract, they prepare the prostate fluid towards the, let's say, the urethra. So this is in general the normal breast, how it is made, and the breast tissue is hormone sensitive. You will see that when, for example, before puberty, the male and the female breast tissue is just very small. But when puberty comes, because in females they have now production of estrogen and progesterone in high quantity, then the breast also develops. And also, you have seen that when a woman is pregnant or if she's breastfeeding, the size of the breast will increase because the secretory cells will be sensitive to progesterone, and they will make a lot of milk. So to make a lot of milk, they need to have what you can say hyperplasia. So the number of epithelial cells will increase, and thereby the size of the breast will increase. And of course, this is also influenced by other hormones such as oxytocin, which is responsible for milk to get out of the breast. We shall see this maybe in the endocrine system pathology. So the first thing we can discuss here is the galactoria. So we start diseases or abnormal conditions. So galactoria refers to the milk production outside of lactation. So it is not a symptom of breast cancer because usually nowadays, because the women are aware of the danger of the breast cancer, whenever they have an abnormal thing on their breast, they come straight forward to healthcare system, fearing that they may have a breast cancer. So the cause include nipple stimulation, which is the common physiological cause. For example, stimulation by the baby or anything else, or there is a problem with prolactin, which is, it is a hormone made also by pituitary gland. So if then the pituitary gland is having a tumor in cells producing prolactin, this tumor will be called prolactinoma. You understand that the pituitary gland will release too much of this hormone, and this hormone is the one responsible for milk production. So this one is responsible for milk production, prolactin, while there is oxytocin, which is responsible now for propelling the milk up to the nipple. So there are two hormones having different functions, as we shall see in the endocrine system. So of course, when this comes, it can be a sign of something abnormal. Hari abadamu bagira ibindi bita like retention of the milk. Hari abayigira akaza ari no muri menopause atakibyara, ariko akaza hari milk iri kuza. So ibyo nabyo turabibona kenshi. Another thing, they may be having an abscess because sometimes the pus can look like milk, but in the case of abscess, she will have a fever and so on. Ariko ikindi kibazo yari nuko niyo ari amashereka yagumyemo ari menshi, nabyo bimurya hakaba inflammation ku buryo ushaka kwitiranya na abscess. So that's why the proper investigations are needed in such cases. And wenda nta ndabivugira, hari indi danger tujya tubona abadamu bagira nk'iki kibazo cya abscess wenda in their breasts. So, and they come to healthcare facility, and the doctors will be just happy to give them antibiotics and the anti-inflammatory drugs. That can help for a time, and sometimes that the signs and symptoms disappear completely. But the issue is that if that pus is not removed, you treat it medically, not surgically, there will be a very large scar. So in French, it is called antibioma. It means like a tumor rising from antibiotics. So if I can say so, but it is not the definition. So it is a mass which is developed after giving antibiotics to someone having an abscess instead of doing incision and drainage. So must incise and do drainage of the pus, and it maybe add antibiotics to prevent maybe the spread of the infectious agent, but to give antibiotics alone will relieve that mass. And the woman would be she would be finding that now they gave him antibiotics, now the mass is fixed and it is hard because it becomes hard. So she would fear that it may be a tumor or a cancer. So inflammatory conditions, we'll start with acute mastitis that you can see here. There is redness, there is swelling, and you can see that it is as if there is a fluid inside which want to burst the skin here. So bacterial infection of the breast is usually due to Staphylococcus aureus. It is associated with breast feeding. So usually when a woman is breastfeeding, it is when they develop this acute mastitis. So fissures will develop in the nipple, providing a route of entry of microbes. So this is the pathomechanism for that infection to happen. So there will be erythematous, so redness, breast with purulent nipple, discharge, and they may progress to abscess formation. So this is where I was saying it can be pus and you can confuse it with milk. But if you, for example, you look at the temperature, so usually in abscess they have a fevers, unless they have taken drugs, antibiotics or anti-inflammatory drugs. Treatment involves the continued drainage and antibiotics, such as dicloxacillin, of course, if it is not resistant nowadays. So there are factors listed here: trauma on the skin or the nipple, example fissures that we mentioned here, nutritional, trace element or antioxidant, because these intrinsic factors such as mid-range maternal age, it is seen that it is actually at this age range that the women are more prone to develop this. So they have or fatigue, employment outside the home, primiparity, meaning that it is the woman is having her first child, previous episodes, and so. Yes, some things you cannot link it straightforward to this. For example, having fatigue or employment outside the home. So it depends on studies. If studies have been done, they compared those who work at home and those who work outside the home. They found that those who work outside the home, they are more prone to develop this, but it is not easy to explain that. So genetic factors such as HLA status, family history, immune factors, raw milk cell counts, raw milk lactoferrin, raw milk lysozyme. You know, this lactoferrin and especially lysozyme, they destroy they destroy bacteria. So if now in the milk they are low, it means bacteria which will be there, they will not be destroyed. So they can grow and then cause inflammation or abscess. Okay, so another condition is periductal mastitis, which is also inflammation. I think you are familiar with this. When there is a word, there is an organ, then you add a suffix itis, it refers to the inflammation of that organ. So gastritis, dermatitis, and so on. So this is the inflammation of the subareolar ducts, usually seen in smokers. So they have a relatively vitamin A deficiency, which results in squamous metaplasia of the lactiferous ducts, producing duct blockage and inflammation. So you can understand these ducts, they are lined by simple Okay, pseudostratified columnar epithelium. So because we have skeletal cells, which are columnar, and then behind them we have the basal cells. But if these ducts, they become metaplastic and they become lined by stratified squamous epithelium, we understand that stratified squamous epithelium is thicker than the pseudostratified columnar epithelium. Therefore, if there is stratification of the epithelium, the caliber of the ducts will be decreased, and thus the blockage of the milk passage will happen. So they will present with subareolar mass with nipple retraction. So this will be worrisome because whenever someone has a mass in the breast and there is a nipple retraction, it is a sign of cancer. So that's why when you have such a woman, first of all, you have to rule out a cancer, and this will be done usually using pathology. Otherwise, radiology will not help much. So here there is classification of mastitis. There's infectious, non-infectious, and the malignant one. In the malignant one, we have what called malignant inflammatory carcinoma, which is very, very, very dangerous. It is really very dangerous. Inflammatory carcinoma. Because umudamu cyangwa umukobwa uyifite ubona afite akabyimba gato mu kanya umusuzuma hashira amasanga ugasanga yabyimbye. Umunsi wa kabiri usanga ibere ringana umusozi, ryatinda iminsi ibiri ugasanga n'indi ryafasha. I remember case we had, I think in 2014 or 2015 at our hospital. So yaraje afite akabyimba gato, so surgeon saw her, so bamuha rendezvous kumukorera ibyo bagomba kumukorera, ariko asuye mu mwanya mutoya atangira kubona ko kari kubyimba cyane, aza ku bitaro. Mu gihe akiri aho ngaho araremba, so bamushyira mu bitaro. Bukeye atangira kugira pleural effusion. So nibwo batubwiye so we took samples from the chest, from the pleural cavity, and from the breast. So it was confirmed they are malignant cells. So nyuma gatoya umunsi ukurikiyeho n'irindi bere rirafatwa. So it was not possible to save that woman because because even if they gave chemotherapeutic drugs, so muri cases zimwe na zimwe ushobora kuvura umuntu what we call empirical treatment. Nk'uwo nguwo ubona ko byase biba confirmed ko afite inflammatory breast, ntabwo ashobora kujya muri processes yo kuvurwa nk'iy'abandi, ko abandi binyura ahantu henshi, gukora za scanner, gukora immunohistochemistry tukamenya imiti yamuvura iyo ariyo. Ibyo ni ibintu twari by'umweru. So for this case, it was not possible to do that. So she had to start the drugs empirically, not knowing what receptors she has, at least to try to save her. So you consider to give her the drugs which are more likely to act on her. So ujya muri epidemiology ukareba ubundi abarwayi dufite twagize percentage nini ifite estrogen receptor or progesterone receptor was positive and so on. So now ngaho ugenda urebye na ash mu gihe ugitegereje ko byo bizapima. So she was put on that, but because she had already metastasis, byarihuse cyane. Mu masaha makeya mu bihaha byafashwe, mu yandi masaha makeya ubwonko byagezeyo and liver, so it was metastatic, and so the treatment became just palliative, and it lasted just a few days. Missing hitatu cyangwa ine yaramaze. So inflammatory breast cancer is an emergency. Another thing is malignant abscess. So something which can look like an abscess, but being malignant. So I think I mentioned once that there is a small child, a girl who she was 13 years. She had a mass. Then the biopsy was taken. It was very inflammatory. So because the biopsy was small, it was reported to be an abscess, but because there were some cells which we requested to repeat a biopsy. Biopsy was repeated, then it was confirmed to be a cancer with an abscess. So she was treated, but the treatment was not successful. So she died, I think, some months later. So, and then we have others, non-infectious, like this ductal ectasia, niyo navuga ko amashereka aba blocked, so we call it ductal ectasia, and we have many cases here, and so on. Diabetic mastopathy, post-radiation, muzamubona abadamu bakorewe radiation, banyuze muri radiation i Kanombe, batangira kubyimba, cyane cyane ukuboko rimwe na rimwe kukabyimba, nyamwe twabivuzeho ubushize, biterwa n'uko lymphatics, when they are irradiated, they become fibrotic, then the lymph which was passing through there will no longer find their way, its way back to the bloodstream. So ibyo bituma amaboko y'ababyimba either kwa radiotherapy cyangwa se hagiyemo cancer cells which will block the lymphatics. And it is the same, the surgery. Because the surgery, when you suture, you cannot suture vessels individually. Therefore, if you have cut lymphatics, it is possible that they will be blocked. And then after surgery, you find someone has a very much swollen upper limb. So otherwise, other things you can read here. So the mammary ductal ectasia, it is inflammation with dilation or ectasia of the subaerial duct. It is rare and classically arises in multiparous postmenopausal women. So although they say it is rare, I think for us and in our context, it is the one of the most lesions we see in the pathology, at least at East Africa. So of course we have tumors, cancers, we have benign tumors in young ladies, but this ductal ectasia, we see it also frequently. So there will be a green-brown nipple discharge because of the inflammatory debris which will be coming out. Chronic inflammation of plasma cells is seen on biopsy. So here we have a diagram. It is talking about the how you can interpret a nipple discharge. This is very helpful, especially when as a general practitioners, if you have a woman with a nipple discharge. So how will you go on to identify what is the most likely diagnosis? Because the nipple discharge is not a diagnosis; it is a sign. Then you must do further assessments to know what is the diagnosis or the cause of discharge. So when it is bloody, it is reddish. Usually it is due to what we call intraductal papilloma. We see it. It is a benign tumor arising within the ducts, large ducts of the breast. When it is brown, so it is a fibrocystic disease or mammary duct ectasia. When it is clear, usually it is also mammary duct ectasia, and you see that the mammary ectasia can present as either clear discharge or brown discharge. Green is seen also in the fibrocystic disease. Yellow, it is infectious, so usually this is pus. It is yellowish. While milk is seen in the breastfeeding or hormone-related causes or galactoria. So this, looking at the color and asking if she has sometimes a fever or not, it can help you to identify the cause of the nipple discharge. So fatty necrosis, nayo ni imwe mu bintu bigaragara nka breast cancer cyane, ndetse no kuri histology. Kuri histology, when they have taken a small biopsy, it will be very difficult to know if it is fatty necrosis or not. Because in fatty necrosis, the cells become ugly, they look like cancer cells. So you must be very strong in histology or histopathology in order to distinguish these two. So also clinically, there will be skin retraction, which is a sign of breast cancer also. Nipple retraction, and so on. And skin tethering or dimpling. So mu Gifaransa ni sinye bita peau d'orange. Peau d'orange, you know the orange fruit. So how its skin is. So the skin of a breast with a cancer or breast with a fat necrosis look like that. That's why you will find even in English literature they use that terminology of peau d'orange. It means the skin of orange fruit. So usually it is related to trauma, ariko akenshi umurwayi araza akaba ati ariko nta kintu cya trauma yigeze ngira, umugabo yaragukubise cyangwa hari umuntu wakurumye iki, hari ikintu byakubwa akaba no. So sometimes no history of trauma. It presents as a mass on physical examination or abnormal calcifications on mammography. And whenever there are calcifications on mammography is a X-ray of the breast. So I think in Rwanda, maybe 4 hospitals have this machine. It is not just the regular X-ray, it is specific for the breast. So I think Butare should Sashibe, Sashika, Kanombe, and the Vice working Vice, it is where we have them so far. So biopsy shows necrotic fat with associated calcifications and giant cells. This is multinucleated giant cells which are trying to engulf that fat which escaped from the cells. So before going to the tumors now, we can have a discussion if you have questions. Okay, so it seems there is no question. Okay, so we start with fibrocystic change. So iyi muri rusange icyo navuga uburwayi bw'ibere ku badamu, ku bakobwa, abakobwa bo bakunda kugira iyo fibroadenoma. We shall see it after this. Fibroadenoma ariko iyo yayitindanye fibroadenoma undi tibara ko iba ku myaka kuva tuvuga 20, ariko n'ejo bundi Wednesday I had two girls. One was she's just in second year of secondary school. Undi yiga muri kaminuza ariko aracyari mutoya. So they had the breast masses so bataragira imyaka 20. Nubwo rero tuvuga imyaka 20 fibroadenoma itangira, ariko hari n'abayigira bakiri bato cyane. So when they reach 30 years, usually it is not only fibroadenoma, usually there are cystic changes which happen. So all of them they are benign, ariko concern hari nuko iyo umuntu agize fibrocystic disease and it is not treated, it can trigger the development of cancer in the future. I think you remember in the risk factors for breast cancer we saw in the general pathology, there are it was mentioned benign breast lesions. So these benign lesions, when they are left untreated, they can trigger around them the development of cancer. So therefore, when a woman is having fibrocystic disease, it is not a good sign. So it is there will be fibrosis and cyst in the breast. Most common change in premenopausal breast thought to be hormone mediated. So there will be irregularity in the breast tissue. So bagira ibibyimba, ariko ntabwo ari ikibyimba uparupa ngo wumve ngo kigarukira hano cyangwa se kiri smooth. So it will be just an irregular hard tissue. It will not be encapsulated, so there will be no capsule. So the cyst, they have a blue dome appearance on gross examination. So this is here, it is a normal So, okay, so it is gone. So here on the left, upper left, you have the normal breasts. We have a fat here. We have the glands here, or the lobules, and the ducts which come to the nipple here. The areola is around. So below here we have muscles in the 2 layers, and then we have ribs, and between the ribs, of course, we have muscles. Then we have, this is the intrathoracic area. So when it is fibrocystic, you see that there are irregular masses and everywhere. So it is not one mass. So the causes are listed here. So you have lactation refuse. It means someone who don't breastfeed. So abo barahari niyo mpamvu navuga bushize muri risk factors of breast cancer, for example. It is not just enough to have a child to be protected. So you must breastfeed that child, because when you breastfeed, you prevent the development of these diseases, but also you decrease the exposure to estrogen, which will help you to prevent also breast cancers. Obesity, we mentioned, the smoking, alcohol, genetic predisposition. There are people who are genetically predisposed to develop this. For example, if a young girl develops these tumors, that means there is genetic predisposition. Those who don't have pregnancy or who have abortions, genital organs diseases, irregular sex life. So you understand, you understand that's here on this picture. So this lady has maybe irregular sex partners, and so sometimes she has a husband, and another time she hasn't. So this is a risk also, or having a late pregnancy. Ngira ngo ibyo murabizi, no kuri breast cancer, one of the risk factors ni ukugira umwana wa mbere nyuma y'imyaka 35, cyangwa se ukamugira ntiwonse mbere y'imyaka, so or breast trauma. So this is what is, so on histology, usually fibrocystic disease, it looks like a fibroadenoma. So you have increased glandular tissue, hyperplasia, but also hyperplasia of the stroma, fibrous tissue. But what is added in fibrocystic disease, nukuona ko harimo na twa cyst that just there's masses filled with fluid. So on cytology, because we have individualized cells, when we see fibrous cells and the breast epithelial cells which are increased, and we see added macrophages, we confirm this is a fibrocystic disease. So macrophages will help us to determine that the woman is not having only fibroadenoma, but there is fibrocystic changes which happen. So here it is histology. So it's the benign, but some fibrocystic related changes are associated with an increased risk of invasive carcinoma. So this is what I was explaining before. So we have a ductal hyperplasia, atypical hyperplasia if it is there. So if we have fibrosis, cysts, and the apocrine metaplasia, there is no increased risk to develop breast cancer. But when there is another sclerosing adenosis, the risk of developing the cancer is 2 times increased as compared to those who don't have this. And if there is the atypical hyperplasia, meaning that there's hyperplasia, but some cells are not good. They look like atypical. Atypical means dysplastic. So this means this will have a 5 times increased risk of developing breast cancer. So intraductal papilloma twabivuzeho kare, abayigira bakunda kugira bloody nipple discharge, iba amazi atukura aza muri nipple umako. So here we have a breast tissue. This is a diagram, of course. We have a lobule and the ducts, and when you look into a duct, you find that there is here a mass which is inside the lumen of that cavity, duct, with its stalk. So its stalk niyo inyuramo amaraso niza gutunga iyi. So this is a diagram. So this is a true picture on histology, the way it looks like. So here you have a duct with its lining epithelial cells, and here this is the lumen, which is white. And then you find this papilloma, or it is like a polyp with a stalk here. So this is how they are. So ikibazo nuko rimwe na rimwe this can also be transformed into a cancer, but it takes time. So this means if a woman finds a bloody discharge or reddish discharge in her nipple, if she comes to the health facility as early as possible, the mass will be removed to prevent any occurrence of the tumor afterwards. So the fibroadenoma niyo navugaga ikunda kugaragara mu bantu bakiri batoya, abakobwa bakiri bato. So the median age is 20 years, but as I said, we have younger ones and we have older ones. So when it reaches 30 years, usually there are fibrocystic changes which are added. So icyo tubadanga nuko haba hari, it is just the most common benign breast tumor in premenopausal women. So it is well circumscribed. Niyo iparupa ubaumva ko the mass is mobile, well circumscribed with a smooth surface. This is because it has a capsule. And this is different from the fibrocystic disease, which has irregular surface without a capsule. So benign, there is no increased risk of carcinoma in itself. Usibye bya bindi twabonye muri general pathology bako iyo ubwayo ntabwo ari ivamo tumor, but the tissue around it is more prone to develop cancer as compared to those who don't develop the fibroadenoma. So hari nabo usanga afite cyane cyane mbona ku bakobwa batoya imyaka 18 cyangwa 20 aho ngaho baba bafitemo twinshi, rimwe na rimwe akagira no both breast. So it happens. So Philodes tumor, here we have a proliferation more of the fibrous tissue, but the epithelial cells are not much increased. But Philodes tumor, it is considered as borderline. Harizo dusanga ziri overtly malignant, others are just benign, others are intermediate. So whenever we diagnose a Philodes tumor, we have to precise if it is overtly malignant or if it is overtly benign or if it is intermediate, but usually they are in intermediate. So it most commonly seen in post-menopausal women. It can be malignant in some cases, so it is written here. So if you see that this breast is very large compared to the contralateral one, with reddish areas, maybe the nipple to identify it. So it is there is a deformity here. So that's all for benign tumors. So usually they are not worrisome. Usibe ko ubu nyine abantu baza bahahamutse n'abafite cancer yibe. So bose nta kindi akubaza, nta nubwo bakunda kuva aho ngaho mu gihe kibasuzuma batakubaje ngo musanze ari y'amatari. Wambwira uti we are still doing procedures. Kwa bimaze gufata sample ntabwo biba kwihita ubona ibisubizo. Akagira ngo ndo bamwica, ariko bose bari worried about it. Any questions so far? Sorry?
How do we differentiate Philodes tumor fibroadenoma?
How
do we differentiate Philodes tumor fibroadenoma?
You mean clinically or not?
Yes, clinic.
I think hari ibiba byanditse hariya hejuru. Urugero navuze fibroadenoma, it is biranansa in premenopausal women. Philodes in postmenopausal women. That is one. Nubwo hashobora kubaho exceptions, but this is what I said. To become a good healthcare professional, you must know at least the most common things. So fibrocystic disease, Philodes tumor most commonly in postmenopausal women. Fibroadenoma, it is actually in girls, and because it is around 20 years of age. So now we are in a hurry. And then the fibrosis tumor, usually it is not very delimited, so no capsule, usually no capsule. While fibroadenoma, it is mobile, it has a capsule with a smooth surface. So fibrosis tumor ahubwo wavuga ngo na fibrocystic disease nibyo byenda gusa urebye bihuje ibintu byinshi biri muri postmenopausal women, they have irregular surface, so byo birasa clinical. But fibroadenoma and these ones, they don't appear the same. So fibrocystic disease and the fibrosis tumor nibyo kigoye kubibona clinically unless you histology can intervene. Even cytology will not help much. So histology is the one which is helpful. Any other questions?
Question.
Yes.
About we saw about the physiological changes that women who had abortion or no pregnancies are at high risk. My question is, how does it also apply on infertile women?
Of course. Now ikibazo ahangaha the issue is not to have the issue is to have exposure to estrogen, and I repeated this many times. When a woman is pregnant and she breastfeeds, she's more protected because she has a higher progesterone, which is somewhat protective against breast cancer. And then if someone becomes pregnant and then there is a miscarriage or abortion, you understand that she will have a short period of protection as compared to the one who has a pregnancy, a term pregnancy and breastfeed. So that is the explanation. And of course, those who have no child will have a higher risk. So it was written some. Absence of pregnancy, yeah, it is here. Abortion in absence of pregnancy. And any other questions? So if not, we proceed to this next part, the breast cancer. So the basic principles is that there are symptoms of breast cancer. So there is a nipple discharge. So ishobora kuba amazi, ishobora kuba just a watery, it can be reddish, it can be purulent. So there is no specific color of this discharge from breast cancer. So meaning that whenever a woman is having nipple discharge, you have to investigate or to assess and see if it may be a cancer. Lumping or thickening. So lump ni ukuvuga afite ikibyimba kigaragara cyangwa se thickening ukumva ko ari ibintu bikagashe. So I remember, maybe I said this in I think in January. This year there was a woman, she came, she said, I have just a lesion here on the breast. So when you examined, there was no tumor, no mass per se, but the skin of that breast in one area around the areola was hard, was thick. So then I said maybe it's better we go to ultrasound and examine using that imaging. So when we reached there, also they found that the breast itself has no problem, but just below the skin, I can say inside the dermis, there is an issue. So then I took cells. So the cells were malignant. So I confirmed this is malignant, and they are looking ugly, very atypical cells. So I thought this is aggressive cancer, though it is starting. So because this woman, we could save her very easily. So I told her she was sent by Muhima Hospital. So I told her that I will not allow you to go back to Muhima Hospital. So I wrote a document to justify why she should remain at our hospital. But when she went back home, she has her sister-in-law, who is a nurse. But I didn't know that. But I think she works not in Kigali. Then that sister-in-law told her, okay, you know, I know someone who can help you. Bandi bavuza ibyatsi cyangwa ibindi ntabwo nzi ibyo bavuza. So amujyanayo. So amujyanyeyo turamukurikirana amuhamagara ngo urumva ngo afite ibibazo ngo muri famiye ngo ndarwaje ariko se urarwaje niba urwaje hari undi ushobora kuba urwaje hari undi ushobora kumurwaza kandi ufite ikibazo uzi ko icyo utifuza. So akomeza gutyo abayo nyuma aza kumbwira. So because I used to follow this case asking them how they are doing. So ageze arambwira ngo nkubwize ukuri nagiye kubivuza muri abo bavura niba ari sinzi uko byabita traditional healers, ngo kandi ngo mbona biri kumfasha. Biragufasha gute? Ngo urumva ngo bambwiye ibintu byo kurya bizamfasha ngo kugira ngo ikibyimba kitazakura ngo ahubwo kizashonge gishire. So I just, okay, that is your choice, but whatever will happen uzabyirengera. So ariko arambwira ngo ariko nubwo bimeze gutyo umugabo yaramwinginze ngo aze akomeze yivuza arabyanga, ariko aramwihora ngo iyo ni choice yawe. Noneho umugabo w'uwo mudamu w'umunasi nukuba ni umusaza we barabipfura bati abantu barakuvuye bakone indwara ikiri hafi wanze kwivuza, kuva ubu ngubu ntituzongera no kuvugana nawe. Asa n'ababaye abanze ko yanze kwivuza. So then it took like 4 months. Then she came back to the hospital. The mass was very large now. The mass was large. The whole breast was filled. Just byari byuzuye mass. Kandi aza mbere breast was almost normal except that skin niho mbikute cyangwa just thickening of the skin. There was no mass per se. So after days of 4 months she came, the mass was very much large, but she was lucky was no lymph node involvement, meaning that the cancer has not metastasized into the axial lymph node. So then so I helped her to get as quick treatment as possible. So the biopsy was taken. We did immunohistochemistry to see which drugs will react. Then we sent her for treatment. So I think she came just like 1 month ago or 2 months ago, just for checkup. So mbona noneho mass yaragabanutse, and ngira ngo ashize nk'ibyumweru bambwiye ko ibitagiye kuyirangiza phase ya mbere ya injections. Avuga ko ngo nta kibyimba yumva uretse ku ruhu ko hasigara ikibazo, ariko icyo gihe bibyimbye ajya gutangira imiti. So the mass was even fixed on the muscles, so it was very worrisome. So if she could have been treated as early as possible, nta n'ibindi bibazo bafite abameze nk'abandi ari normal, but it will take her time if she's lucky to be cured. So I was explaining that the cancer can present as just a thickening, not a mass. So a mass here is a lump. So a lump can be felt on palpation. So nk'umuganga ntabwo ngomba kwibwira ko breast tumor ariwo uzabona aho iri kurusha umurwayi. So it is normal. So uza muri stage ukabona umuganga abwiye umurwayi ati nyerekaho akabyimba ntuzavanga umuganga ntazi gusuzuma. It is known. Umurwayi niwe ushobora kukabona izire kurusha umusuzuma. Kuko hari n'igihe aza akaba ati mfite akabyimba noneho akagashaka kakabura nawe. kwako akenshi they are mobile, aho wakabonye none aka kanya mu kanya gato usanga kwimutse tumwe na rimwe kakabura burundu. So and usually we go then to examine them under ultrasound to see really where is the mass. So there is a dimpling of the skin, bya pod orange navugaga and so on, and there is pulled in nipple. So ahangaha language yakoreshejwe ntabwo ari medical in general. So pulled in ni ukuvuga retraction. So nipple retraction niyo medical term. I dimpling ni pod orange. So skin irritation, armpit pain, and this can mean that probably the lymphatics are being zatangiye kugira ikibazo and obstructed or inflamed because of the cancer cells going there. Skin texture change. So I think this can combine with dimpling and so on to make the pod orange. So in general, this is what you see. Angira ngo hari ikindi navuga hangaha cyane cyane nko ku bagabo akunda kugira araza akakubwira ati jewe njya mbona ibere rigyimbye cyangwa ryiyongereye ngo ariko ribyimba cyane nk'iyo nkoze siporo cyangwa nteruye ibintu. So when you see that akubwiye gutyo, this is very dangerous. Usually it is a breast cancer. So I remember there is umugabo yaje mwaka ushize ariko yaje kundeba kuko ari mushiki we twiganye secondaire, hanyuma amubwira ko cyangwa ati umuntu wagufasha araza. So then abwira ko bimeze. So namwe ngo iyo nkoze siporo gira ibibazo binini nibwo habyimba no mu kwaha hakabyimba. Yeah, that is a danger sign. So the biopsy was done, it was confirmed to be a breast cancer. So then I sent him to a surgeon. The breast surgeon will have, so ntabwo ari benshi dufite, ashobora kuba ari umwe akora research. So aramubaga byihuse. So I think they met in a private clinic. Niho yamubagiye. So nyuma yaho kubera ko afite abantu baba muri Belgium, ajyayo yivuriza agezeho bamusuzuma bati turabona ibyo mu Rwanda bakoze nta kindi kintu twakongeraho ko bakoze neza n'ibindi. So bamuha imiti aragaruka, imiti akomeza gusa gufata. Icyo nashaka kuvuga nuko nta yindi sinye igaragara afite usibye kuvuga ngo ibere rye rirabyimba gato ndetse no mu kwakabyimba cyane cyane yakoze siporo. So this armpit pain or sweating, especially when he has done exercises. So the types of breast cancer. So as I said when we started, we have ducts, we have lobules, and so on. So then a breast cancer can arise from either ductal cells. In that case, it will be ductal breast carcinoma, or it can be arising from the lobules here, and it will be called the lobular carcinoma, breast lobular carcinoma. Sometimes it will produce a mucin, too much mucin. In that case, we call it mucinous breast carcinoma. And inflammatory nerve is very aggressive, which can kill just in a few hours. So it is another type. Of course, hari n'izindi subtypes nyinshi ziri mixed. Hari n'iyo usanga ifite ivanga stroma cells and the breast cells and the epithelial cells themselves. So I remember there is even a case we published a few, last year, or in 2020. So it was just looking like a squamous cell carcinoma of the cervix. So it was unusual, that's why we published it. So we call it metaplastic carcinoma. So this is the most common carcinoma in women by incidence. So nubwo hano bavuga excluding skin cancer, ntabwo nko mu Rwanda ntabwo tuya skin cancers nyinshi nka breast. So I think biterwa n'ibihugu, ariko muri rusange ku isi yose niyo this is the most common cancer. Ikindi babanditsemo excluding skin cancer nuko muri cancer registries, nubwo registry bandikamo all cases of cancer bakanazikora follow up, akenshi skin cancer ntibayandika. Mpamvu batandika nuko bati kameme umuntu atekereza n'ute agira akabyimba kuri skin kagenda kavamo cancer yamuhita. Bityo bashaka kwandika ni izishobora guhitana abantu. so abazungu ntabwo baba babyumva kuntu ibyo bihe, ariko hano turazibona nyinshi aza yaramurenze kandi skin ayireba buri munsi. So it is the second most common cause of cancer mortality in women. The risk factors most related to estrogen exposure. I think we had the two or three slides on this when we saw general pathology, neoplasia. So female gender, of course, because of estrogen. Age usually arises in postmenopausal women with notable exception of hereditary breast cancer. Ari menarche rate menopause barabisobanuye. Menarche no kujya mu mihango bwa mbere ubigiyemo akiri muto, no kuvuga azagira igihe kinini cyo kuba exposed kuri estrogen. Estrogen ntabwo ishobora gukorwa hatabayeho ovulation. Ovulation ibaho, yibayeho nibwo umuntu ahita ajya muri menses, kandi menses nizo menses za mbere, cyangwa se uzatinda kujya muri menopause nawe azaba yagize igihe kirekire cyo kuba exposed to estrogen. Obesity, atypical hyperplasia, we saw it. First degree relative, mother, sister, daughter with breast cancer. I think I gave scenarios, examples I know personally about these cases. And so we had many other risk factors, of course. Ibyo kuba tarabyaye cyangwa hano ntibariko so kuba tarabyaye nulliparity cyangwa arabyaye bwa mbere akuze, kubyara hano navuze ko bijyanishwa no konsa, of course. So hano muri breast cancer rero hari n'icyo twita ductal carcinoma in situ. You remember that when we say carcinoma in situ, they are cancer cells but they have not yet breached the basement membrane. So they are not invasive and have the shock metastatic events. But because usually a woman with ductal carcinoma in situ, if this is not treated, she's prone to develop now an invasive cancer. This is also when we see it, this we consider it as okay, it is treated like a malignancy. So aggressive, that is what I mean. So you will see calcification on mammography. So that you will see no mass. Ntabwo wamparuka ngo uvuge ngo numvise mass yari kuko ductal carcinoma in situ twari utuntu duto cyane, ntabwo wamparuka. So but mammography will then we have the duct. So these are normal ducts. When it is a ductal carcinoma in situ, the abnormal cells usually fill the ducts, but the basement membrane here around it will be intact. And now the lobular carcinoma in situ is the counterpart of the ductal carcinoma in situ. Ariko muri pratique, ufite lobular carcinoma in situ ntabwo afatwa nk'ufite aggressive disease kimwe n'ufite ductal. So ductal carcinoma in situ is more worrisome as compared to the lobular carcinoma in situ. Ibi binatuma niyo tuyibonye iyo tubonye carcinoma in situ ariko tukabonamo na invasive cancer, byombi tugomba kubiripotinga ko byasanzwe ko umuntu ufite invasive cancer wagenda afite na carcinoma in situ n'ufite byombi ntabwo bagira prognosis. So we must always report if you have done, we have seen ductal carcinoma in situ in addition to the invasive cancer. So now the ductal carcinoma in situ, this is the most common cancer of the breast. So niyo nyinshi kurusha lobular carcinoma. So lobular ntabwo ari nyinshi, ushobora kumara nk'umwaka personally wenda mbonye nk'eshatu, ariko ductal carcinoma almost every week have 1-2 cases. Me and my colleagues also, they see other cases. So there are many cases. So this is having a calcification aho ubururu cyane calcium, when it is stained with hematoxylin it becomes very blue. So niri ahanga this calcification ni nayo kuri mammography bazabona ko harimo opacity. So usually it can not usually, sometimes it presents with what we call Paget disease. Nyangushyize nawe bivuze Paget disease of the breast, noneho tukagira na extramammary Paget disease ifata muri vulva niyo twarebaga kandi ifata muri bones. So the target disease of the breast uzarangwa n'iki? Akenshi ni nipo ifata, usanga nipo ntayiri, ukagira ngo ni ikintu cyaje kiyicaho kirayitwara, ukabona hari nk'agasebe. So when it is like that, then usually it is a target disease. So target disease is a ductal carcinoma in situ which extends from the ducts up to involve the skin of the nipple. Ni icyo kibitera. Gusa iyo witonze, akenshi baravuga ngo iyo witonze neza muri breast hari aho usanga noneho harageze na invasive cancer when you see target disease. And we have a diagrams here which are showing that. So invasive ductal carcinoma, then itself, it looks like it arises from the ducts, not from the lobule. So you see here a normal duct with its lumen. We have the lining, the secretory cells, which are whitish. Here you see that these blue cells, they are malignant cells, and they tend to occlude the lumen. So when these malignant cells have breached the basement membrane here, now it becomes an invasive cancer. So this is a diagram, of course, and have very reality. So, and you see on histology nukusanga kameze. Urabona ko ahandi hari fat, aho umuhondo ni fat. Ariko nukabona akantu kari white, solid. So you ubonye akantu nk'aka without a capsule, yeah, this is a sign of a cancer. So akenshi ukabonamo kameze gutya ari akanodire gatoya. The diseases, they don't read books. Niko bakunda mu Gifaransa, the maladie ne lisent pas les livres. Hari ubwo usanga afite akamasi nk'aka gato cyane, ariko gasanga afite metastasis nyinshi. Mu gihe wano ufite ikimase kinini muri breast, nta metastasis afite. So nk'uwo mudamu navugaga, nta metastasis yagize n'uwafite ikimase kinini. Mu gihe hari undi waje mbere yo gato, nawe nkurikirana n'ubu, ariko we yari afite akamase gato muri breast. Ngira ngo yanaje arimo kwitembera kwizira ku bitaro, waje kubera iki? Arambwira ngo urumva ngo nanjye ejo narebye televiziyo mbona bari kwigisha ibintu bijyanye n'ikanseri y'ibere, ngo nikozeho kwibere numva harimo akantu, ahita ajya ku Muhima ahita bamwohereza. So but unfortunately she had a larger mass in the axilla, ariko yari ameze neza, nta nubwo wari kumenya ko arwaye. So but when then I took cells, the cells were malignant in both the axillary lymph node and the breast. So nawe yahise akurikiranwa aravurwa. So and her CT scan, control CT scan was showing that the mass regressed much, and she had the large lymph node in the axilla, niyo yari itarashiraho burundu. So the drugs, they help much. So the invasive ductal carcinoma is the most common type of breast, accounting for more than 80%. So the mass is usually 2 centimeters or greater. Ni mu bihugu byateye imbere twebwe na santimetero 15 bazigezaho. So mammographically detected masses are usually more than 1 centimeter. So this means that clinically you can detect it if it is more than 2 centimeters, while on mammography you can detect it when it is 1 centimeter. So ibi bivuga ko rero nibyo bituma ushize nabivuze ko kuri breast cancer ntabwo twaba ko dufite screening, dufite early detection program. We don't have a screening. For screening ni igihe ushobora kwidetecta itaraba hari ibintu byerekana ko igiye kuba, nk'uko tubikora kuri cervical cancer, but here it is not possible. It is not, because the mammography will detect it when it is already there, and then will prevent maybe its growth and so on. So advanced tumors may result in dimpling of the skin or retraction of the nipple. So there are risk factors which we have also talked about: heredity, lifestyle, age, obesity, pregnancy, and breastfeeding. Murabyumva utaratwise cyangwa utaraonkeje. Hormones, estrogen cyane cyane, essential hypertension, diabetes, and so on. So symptoms: rash around the nipple, and you have a lump that feels different from the rest of breast tissue. So kuko muri breast haba harimo some solid tissues. So ubu uzumva amarobire ubu yumva ukayangwa ni ikibyimba, ariko umudamu nyirayo niwe uvuga ngo iki ntabwo ari ikibyimba, hano nta kibazo, ahubwo akamase ubu kumva ko gatandukanye nawe. And have a nipple discharge and so on. So 1 out of 10 women have a breast cancer. So kuvuga abadamu 10 ubonye aho ngaho, ahubwo ni ukuvuga umwe mu badamu 10 she will acquire a cancer in their lifespan, mu gihe cyo kubaho kwabo kose ufasha abadamu 10 ukabakurikirana. So ntabwo ari uvuga ko ari prevalence, ntabwo ari prevalence, kuko prevalence n'uba ubaza aba umurenge utuwe n'abadamu wenda 100,000, nuko haba harimo abantu 10,000 bafite breast cancer, nicyo byabisate. Ntabwo ari byo rero, ahubwo n'uvuga ngo mu badamu 10 ubakurikiranye abakobwa 10 kuzageza bashaje, umwe muri bo azagira breast cancer hano cyo in their lifetime. So kubavura rero hazamo staging, birumvikana as all breast cancers. Wenda ya breast kwa ko nagiye byibandaho cyane, staging ya cancers ntabwo ari ngombwa kwifata mu mutwe, but hari principles ugomba gufata. Ariko nka breast cancer ahari kwa ko nagiye mpura nazo kenshi, zo sana byangiye mu mutwe kuzistaginga, no kuvuga iyo ageze kuri santimetero 2 itarenze 2 ni stage 1, hagati ya 2 n'eshanu stage 2, zarenga 5 ikaba stage 3. Ubwo abageze stage 3, noneho stage 4 hazamo metastasis. Na hazamo metastasis, ariko hakazamo now involving other the surrounding tissues. So nk'ufite 4 year after stage 4, nubwo kabari gato kari munsi ya za santimetero 5 navuga, ariko ikaba yafashe muri underlying muscles, itinduka 4A, yaba yafashe muri skin kaba 4B, yaba yafashe byombi, yafashe skin and the underlying muscles ikaba 4C, yaba ari inflammatory breast cancer, nuvuga ubibonye kuri histology ikaba stage 4D. So this is how we do it. So ibyo nabifashe mu mutwe ataro nabishatse ahubwo kubera kubabona kenshi buri gihe ushaka umustaginga kugira ngo umenye uko azavuka. And this is important. This is important because so some of you maybe will do surgery. So you can jump on and do surgery on a breast cancer. This is very dangerous. Ugomba gukora staging neza kandi ukavuga ko iyo stage ifite akamaro. So if a pathologist said the cancer or radiology, the radiologist said this cancer is involving the skin, cyangwa nawe warabonaga clinical ukaba ati nabonye ko ifata skin cyangwa underlying muscle, then you go on you do surgery. So ubwo bizakubaho bizabikureba. Niyo mpamvu mugomba kwiga ibyo tuvuga mukabiha agaciro, kubera ko bishobora kukugaruka kubera just kwibwira ko ntacyo theory zibuze. And everything we do is just evidence based. So no kuvuga iyo yageze kuri muscle or the skin, no yageze kuri stage 4A or 4B, ntabwo wabemere kumubaga. Uko byagenda kose ntabwo wabemere kumubaga, uretse exceptions nke nazo zemeranywa. So ntumubaga, ahubwo you take biopsy, we confirm it is a cancer, and we direct you on which drugs can be given depending on the hormone receptors that breast cancer is having. Then she will receive chemoradiation, meaning chemotherapy and radiation. Actually called neoadjuvant chemoradiation. Ni ukumuvura mugamije kugira ngo ikibyimba kizashonge. Then the stage will be down. So we call it down staging. Niba ari stage 4A or 4B or 4C, kubera cyashonze ikamanuka ikagaba nka stage 3 or stage 2, then ukabona kumubaga. So this is the procedure. So I say this because I know many incidents. Many incidents whereby umusurgeon yagenda akiransa akabaga then yabaga twebwe tukaripotinga as pathology tukabona okay twebwe twasanze umurwayi kanseri yarageze muri muscles na skin yageragamo kubera impamvu kubera ko igeze no muri muscles akenshi nunayibaga ntabwo izashiramo iyo idashizemo rero bivuga iki margins are positive ni ukuvuga wayibaze n'undi ntiwayimazemo so kubera ko iyo abarwayi bagiye kuvurwa ntabwo ari umuntu ufata decision haba inama tumor board then icyo nagiye mbona kenshi ni uko iyo bigenze gutyo the oncologist will say okay umurwayi igihe ntabwo mufata sinshobora kumuvura abasurgeons bamubaze nabi bamujyane bamenye icyo bamukorera kandi babivuga imbere n'umurwayi yumva aho ngaho so that's why you must keep in mind everything you say here because it is important so hano mu Rwanda noneho haba n'ibintu byo kuregana kufungisha utuntu twari twose ndavuga mu bijyanye no kwa muganga then we understand now the implications so hano n'ubu umurwayi abyumvise gusa ngo bamubaza atama kumubaga cyangwa bamubaze nabi ubwo ni mu kanya ribu cyangwa polisi bihageze nicyo bivuga so you will be very careful about respecting protocols. So that's why if the pathologist says this stage and so on, you have to be careful. Or the radiologist says muscles are most likely taken. Ariko kuri breast cancer nta nubwo bigomba nabo bose. Now clinically, if the tumor is fixed to the chest, it means it affected the muscles. Ntabwo uba wemerewe kumubaga. You just take biopsy, then pathologist will report the type of cancer, the hormone status, and then they will treat accordingly. Umurwayi azakugarukira waramaze kumuha imiti ikibyimba cyarashonze. Ariko nawe usanga muri private baba bati jewe aya ni amafaranga ncitse nintamubaga ubwo ari amafaranga arancitse ukamubaga ubwo uzamenya icyo uzirengera uzabyirengera. So we have the subtypes. Histological subtypes. So muzayamona kenshi tuvuga no NOS. NOS means not otherwise specified. So kuri breast cancer dukunda kubikoresha. Iyo tubona nta subtype special subtypes afite tuvuga NOS. No cyangwa NST. No special type cyangwa NOS, no otherwise specified. So abo ni nabo benshi. Abafite special subtypes na abafite tubular carcinoma, mucinous carcinoma. Hano ahantu hose h'umweru si ukuvuga ko nta kintu gihari ahuzuye mucin. Noneho we have a few cancer cells. Muzamubona tuvuga ngo afite no kubyandisa tumor cells floating in mucus pool. Nkaho ari amaserire ari koga muri piscine. This is mucin ntabwo ari ahantu hatari hari vide mucin, and this is dangerous. Kuyi mucin it dissect fibers bigatuma cancer cells zigera kure vuba vuba. Nabambo abantu bafite cancer when there is a mucinous component, their cancers are more aggressive than those who don't have mucin. So other types are medullary carcinoma, characterized by large high-grade cells growing in sheets and associated lymphocytes and plasma cells. So ntabwo ari nyinshi medullary carcinoma, gusa amaseri zigize asa naho ari neuroendocrine neuroendocrine cells. Nicyo tuzi. So incidence in this of these subtypes increase with BRCA1. So BRCA, this means breast cancer gene 1. Habaho na gene 2. Izi ni genes ziba mutated muri famille runaka nabivuze tureba biriya bya ovarian cancers and so on. Ugasanga niba hari abantu bazifite muri famille bafite syndrome, familial syndrome of developing breast cancer, ovarian cancer, and endometrial cancer. So inflammatory breast cancer characterized by carcinoma in dermolymphatics. So ahangaha murabona iyi ni lymphatic. Murabona ko harimo akabumbe ka epithelial cells zisa n'izi zo kuri skin. These are normal cells in the skin. So we should not have epithelial cells inside there. But here they are there and they are within a lymphatic. Hari nabo, I remember there is a case I saw. Utabonaga carcinoma cells nazi nimwe uretse zari muri vessels ku buryo kumenya ngo ese cancer yaturutse he ntabwo byashoboka. Every lymphatic vessel was filled with malignant cells, but could not determine where are these cells coming from. So it usually takes a lot of time to identify the primary. So icyo gihe tubyita ko afite lymphangitis carcinomatosis. So inflammatory carcinoma has a poor prognosis. I think I mentioned the case we had at Sashuka. So lobular carcinoma in situ. So the basic is the same. So here we have the cancer which are cancer cells filling the lobules, but without breaching the basement membrane. So nabivuze kare ko iyi ngiyo ntabwo ifatwa nk'iri aggressive kimwe na ductal carcinoma in situ. So invasive lobular carcinoma navuga ko ikintu kitandukanya na ductal carcinoma, and this is important for you. Abyandi byose nkunda kutindaho. Ahantu bitandukaniza n'iki? Ductal carcinoma akenshi bari masse imwe. It is of course irregular, but usually it is one mass. But lobular carcinoma usually there are many nodules. You can see even here. Handi mwabonye ko twabonye nodule imwe. Hano afite nodule, afite niyi, nahanga ntabwo ari hazi. So this part is normal. Ahanga urabona afite many nodules. These whitish solid nodules, they are just many foci or foci of cancer cells. Ikindi kibagaragara nuko uretse no kugera many foci in the same breast, they usually have bilateral cancer. So ibyo bivuga ko iyo tumaze gukora diagnosis ko umudamu afite lobular carcinoma muri breast imwe, ubutegetswe guhita ukora follow-up examination in the other breast. Inshuro nyinshi naryo riba ryarafashe, wenda akakiri gato ko ntabwo bikurira rimwe. So that is important. So invasive lobular carcinoma usually multifocal, usually bilateral as compared to the ductal carcinoma. So ikintu rero gituma ziba multifocal ni iki? Amaserire yazo ntabwo yegerana. Kuba ategerana bituma imwe ishobora kugenda can migrate ikagenda igakurira hariya ikabyarira hariya n'indi hariya ikabyara utumase dutandukanye. Ikibitaro no kwizo serire zo ntizijya zifatana. So if you go back to histology, you know that between epithelial cells we have desmosomes, we have other proteins such as caderins. So mu gihe izindi epithelial cells zigira iyi caderin, muri lobular carcinoma it will be lost. I remember just a few weeks ago, like 2 weeks ago, we had the case. So on a histology, it was looking like lobular carcinoma, invasive lobular carcinoma. But to be sure of that, I requested to do immunohistochemistry looking for E-catherin. So E-catherin was positive. Because it was positive, then we confirmed this is not invasive lobular carcinoma. It was invasive ductal carcinoma. So this is they use E-catherin in this case of invasive lobular carcinoma. They don't have E-catherin, and therefore the cells are not cohesive. So when they are not cohesive, they can infiltrate very easily. Ni n'ibintu dukunda kubona muri histology. Iyo umuntu afite breast, no, any cancer, not only breast cancer, any cancer having a very large nest, n'ufite small nest, aba afite tendency ko they infiltrate very easily. Usanga zaracagagwa ibintu byinshi kurusha ufite the large nest. So ni nka kwa kundi bavuga kurwana abarwana intambara. So abarwana mu buryo bwa infiltration cyangwa gucengera. So it is not easy to deal with them. Ariko abagabo bitero wenda ari batayo cyangwa ikinini bari hamwe. Now when you know where they are, it is easy to fight against them. But those who do infiltrations, nkuko bavuga ngo bacengeza, it is difficult. So prognostic and predictive factors harimo TNM staging, birumvikana ni nayo navugaga ngira ngo staging ni ibanzaho ni ya T ya size. So T0 ni igihe utabona the primary. T1, it is when the tumor is less than 2 centimeters. T2, it is when it is between 2 and 5 centimeters diameter in the greatest dimension. T3, it is when it is more than 5 centimeters. Then T4, ho ntabwo biterwa na size, biterwa nuko yafashe skin na underlying muscles, or if it is inflammatory carcinoma. So that was T. So N refers to the lymph nodes. So when no lymph node is affected, we put 0. Turazibara. Turazibara ngira ngo iyo zitarenze eshatu tugira N1. No kuvuga ni lymph node imwe cyangwa ebyiri cyangwa eshatu zafashwe na N1, zarengaho zagera ku 9, so bikaba N2, zarenga 9 zikaba N3, so N3 niyo hejuru. So M is my distant metastasis. So it is X when you don't know. Muri pathology niko tugeza ko ntabwo tuba dufite organs zose aho ngaho, so we don't report that. M, so we put the X. So X akenshi kuri M haba hazuzwa na data zavuye muri radiology usually. Because after metastasis in the brain, in the lungs, or in the liver. So use the whole 1. So M we have it is 1 or 0 or X. So metastasis is the most important prognostic factor. Ngira ngo aya magambo muziki asobanura prognostic ni ukuvuga ni ibijyanye na survival. Prognostic factors ni factors zatuma arama cyangwa se apfa vuba. Now predictive ni factors zituma azareponda ku miti. The factors which can tell you if that disease will respond to treatment or not. So aya ni amagambo atanu. Predictive, it refers to the response to the treatment, while prognostic refers to the outcome, just a clinical outcome, death or not. Here we have the epidemiology of the types of breast cancer. You see that invasive ductal carcinoma is the most common one. So muri rusange ni so hano muri iyi case, this is was just a study somewhere, ariko ikindi hano ni overall survival. Okay, overall survival hano icyo bivuga nuko mubona ko abo umuhondo hano 80 kuri 90% bashobora kumara imyaka 5 bakiriho. Cyatsi kibisi ni kuva 97 gusubiza hejuru, nuko ductal carcinoma ni site gusa, it is not invasive. Byumvikana ko umuntu ashobora anavuga kenshi nta kindi gikurikira. Then lobular carcinoma is site also. And tubular cribriform carcinoma, you see that they have a better survival. And the mucinous choroid carcinoma, when it is treated on time. Then medullary carcinoma and others. So here the metaplastic carcinoma is having a bad survival. And we have here others which are not mentioned. So metaplastic navugaga ibivanzemo, hari bisangamo cartilage, harimo bone, harimo squamous epithelium, and so on. So therefore ntabwo iri kuvuga cyane kuri epidemiology, it refers to the prognosis or the survival of the cases. So uretse staging na type breast, so ductal carcinoma you saw survival yayo ugereranyije na inflammatory breast carcinoma, they are different. So this is according to histology. Now, according to the markers, there is estrogen receptor, progesterone receptor, human epidermal growth factor receptor 2, gene amplification. So even on every case we identify. Even I think Wednesday I had 2 cases of breast cancer. So ntabwo ushobora kuba ngagiye kuvurwa utabanje kureba ibintu. Because iyo afite ER na PR ziri positive cyangwa imwe muri zari positive ahabwa anti-estrogenic agents mu Rwanda utangwa ni tamoxifen. Ni umuti woroshye yabo ntuhenda mituweli zose na mituweli de sante isanzwe wishyura nta nubwo ugira effect nyinshi ku barwayi usibye wenda bya bindi abenshi uzasanga nta musatsi bafite bo bafite uvaho cyangwa ugasanga igihe kiwufite ufashwe n'udusatsi nka tubiri otherwise abandi bagahinduka umukara cyane otherwise it is a drug which is very tolerated so bakunda kufata biterwa n'igihugu protocol cyahise mu myaka 5 hari aho bagera ku myaka 10 so for HER2 new amplification abangaba bo bahabwa umuti witwa trastuzumab ni scientific name but commercial name y'ukunda kuboneka nawe witwa Herceptin ni umuti uhenda uyu nguyu so mu gihe cyashize bawufata amezi 18 ariko ntabafata buri munsi kenshi ni injectable ariko umaraho amezi 18 kigiye kugura miliyoni 70. So I know the government of Rwanda has been negotiating with the inganda uruganda rukora kugira ngo bagabanirize abanyarwanda. It was not easy kubera ko mituweli de sante zose n'izikomeye hano zavuga ko zidashobora kwishyura. So it was not easy for the patients. And usually hari igihe nk'abaganga ugira santima imwe twarimo tuganira n'abandi umwarambye ati jewe umurwayi muherutse kuba ko afite HER2 new ari positive nenda sinabimubwira ndabonaga ari umuntu nyine ntabwira ngo yabona amafaranga tumubwira nti bizam byaraje uzahabwa imiti ni uzavugwa gutya hanyuma ariko habubwo abafite abantu babizi baramubwira ati rero akantu bakubonyemo akantu kazatuma ugura umuti uyu n'uyu hanyuma azakugaruka baza mu muganga ariko rero ngo nyine mwambwira ibisubizo ngo ariko hari akandi mutambwira niki ntakubwiye ko ibintu byose ngo urabona muganga ngo hari akantu bambwiye hano ngo akakanditsa we ngo akangaka nase ugashaka icyaka nyine impamvu ntanabitinzeho nuko kubera ko kameze gutya hari umuti wagufasha ariko guturahenda cyane miliyoni 70 yo mpamvu ntirembe igihe tuzagura imiti yindi dufite ariko nta nubwo tufite urawigura ngo ninde wakuvuga ko giye mvuze miliyoni 70 so aramuzamukana so nukuvuga ko gutanga information uko ziri ni byiza koko hari ubwo abafite ubushobozi utabizi kandi nubwo ataba bafite abashobora kugira aho akomanga cyangwa abandi bakamukomangira hakagerwa ashobora kumwishyura but this is really expensive drug. So ikibazo rero kibiyobo abaye triple negative. So triple negative cases nvuga negative to ER, negative to PR, negative to HER2 new abangaba urumva ntabwo afata tamoxifene nta nubwo afata trastuzumab. Icyo gero afata indi miti isanzwe twakwita chemotherapy kuko ibingi muzasanga bita hormonotherapy. Nuvuga ni imiti uvura ukurikije hormone afite. So icyo yabwa chemotherapy zisanzwe zivura andi makanseri muri rusange ariko survival yabo ntabwo ari nziza. Mu gihe abangaba ari ER positive survival yabo ni nziza. Ufite HER2 new ni ikibazo. Ku buryo ubundi niba umuntu agize breast cancer ugira survival nziza n'ufite ER and PR positive while HER2 new is negative. Iyo HER2 new ibaye positive izi ER na PR zikaba negative nabwo ntabwo ari byiza ko uyu muti urahenda nta n'ikindi umwanya icyo ukora nuko byensira umuti wica amaserire yose afite izi mutations hano ariko iyo umaze kuzica izi dafite kuko zose ntabwo zazifite mutation izi zisigaye zitayifite zigumaho noneho rero ahita ajya kuri standard nk'iy'abandi barwayi ba breast cancer batari HER2 new positive. So ntabwo wewe ko abakize iyo umuvuje uyu nguyu ahubwo agomba guhita akomeza tamoxifene niba ari ER positive cyangwa PR positive. So iyo ari triple negative rero usually it is difficult to treat this one. So ibyo nibyo twita n'ibyo navuga ko so muri pathology cyane ibi biba bitureba kuvuga niba positive niba ari negative. Ikindi navuga ni uko HER2 new tuvuga ko ari positive cyangwa ari negative ariko tugira na option yitwa equivocal. So yiba equivocal hagomba gukorwa iki hagomba gukorwa ibyo bita in situ hybridization. Fluorescence in situ hybridization, which we don't do actually in Rwanda. So icyo rero abagomba kugira fresh biopsy itarabaye fixed, igahita ijya gupimwa bakoresheje iyo method. So iyo niyo challenge tugifite. So there are many studies which have been done kureba a surrogate marker we can use to determine if these are read negative or positive. So ikindi cyakozwe nuko twarerebye abantu bose twabonye bari equivocal, tubohereje aho bakora immunofluorescence, ubundi basanze ari iki. So yango twabyohereje Boston, Harvard University, ariko byagaragaye ko abenshi n'ubundi bahita baba negative, ariko ntabwo ari bose baba negative. So iki cyari challenge when you say equivocal, hakenerwa izindi methods tudafite hano mu Rwanda to confirm if they are negative or positive. So hereditary breast cancer represents 10% of breast cancer cases. I think this is just to read. And BRCA1 and BRCA2 mutations, the most important single gene mutation associated with hereditary breast cancer. So BRCA1 is associated with breast cancer in the ovarian cancer, while BRCA2 is associated in breast cancer, especially in males. So ikindi cyumvikana nuko BRCA1 na BRCA2 ntabwo tuzipima regularly uretse muri research. Ari research ikorwa njyango ushinzwe yavuga hari umudamu wakoraga research kuri ibi ngibi yakoresheje cases nyinshi za Butaro n'iza CHUK, cyane cyane yarebaga abantu bagize breast cancer bakiri bato batararangiza imyaka 35. Abati niba bayifata bagira breast cancer ari bato, buriya bashobora kuba bafite hereditary breast disease, breast cancer syndrome. Ariko report, so fabrication cyangwa se findings yabonye nuko bidatandukanye n'abandi. So ntabwo ari uko bari bafite BRCA1 or BRCA2 bameze nk'abandi. So maybe they have another mutation which is unknown. Okay, so you can see now there's you see that 85 to 90% of cases they have no known genetic mutation. No, ariko suko ko atari badafite genetic mutation, ahubwo indi familial or hereditary niyo badafite. Otherwise, no cancer without a mutation. So breast cancer cases with known hereditary mutation. So BRCA1, you see that it is the most common, 30%, and BRCA2, 30% also. But you have others, Lynch syndrome, about mismatch repair. I think we saw it in when we saw the colorectal carcinoma, and you have many other mutations here. So women with a genetic propensity to develop breast cancer may choose to undergo removal of both breasts, bilateral mastectomy, to decrease the risk of developing carcinoma. But if you have because breast tissue sometimes extend into the axilla or subcutaneous tissue of the chest wall. So ibyo bivuga ko yego risk bigabanutse, ariko kubera ko breast tissue twabibonye muri embryology ko breast tissue is ntabwo igarukira aho tubona nka breast honyine n'ahandi hari ubw'ibihano. So ntabwo rero bivuga ko bikwema, ariko it decreases the risk. Iki ariko gisana ko niba bandi bakora genetic testing agasanga mugabo muri family bafite BRCA1 or BRCA2 mutations, then akaba ati jyaho kwa muzarwa breast cancer ni muyakoye bakirika. This is njyago nta case nzi ya hano mu Rwanda byose bibaho, cyane ko genetic testing tutayikora uretse muri research, muri za research, kandi aho ngaho bigamije ibindi, ntabwo bigamije ngo tubigendereho dufata izindi decisions. So we end with male breast cancer. It is rare. It represents 1% of all breast cancers. So young research kamaze kubona nk'abarwayi batatu gusa ba breast cancer. Maybe there are more because we are more pathologists. There are other pathologists. So they present with subareolar mass in older males. The high density of breast tissue in males is underneath the nipple. That is the explanation. So they may have also nipple discharge. Most common histological subtype is the ductal carcinoma. So lobular carcinoma in situ is rare because they have a few lobules maybe. So as we saw on the previous slide, see, this is associated with BRCA2 mutations and Klinefelter syndrome. Abandi bagira za chromosome X cyangwa Y nyinshi. Ifite chromosome 47 bamwe. So, you remember better than me about this. So nicyo twavuga, otherwise so ikindi ariko tutabura kuvuga abagabo kubera ko bafite a small breast mass, a breast tissue, a small breast tissue. Iyo afitemo breast cancer, it is very easy to metastasize. Mu gihe ku badamu imaramo igihe ikura kurufita yabikuriye, ariko ku bagabo ntahari ijya muri lymphatics. So that's why unfortunately usually they come with metastasis in the brain or in the lungs or the liver. So nicyo twabivuga muri rusange. So nukuvuga niba hari umugabo ufite cancer ya santimetero 2 n'umugore n'abagore bafite santimetero 2, uzasanga abagabo hafi ya bose baragize metastasis, naho abagore ari bake cyane muri bo bagize bafite the cancers of the same size, because the soulmates, they don't have enough area to invade before invading the vessels. So that's all for this presentation. Any further questions?
Question.
Yes.
How about those, there is like young boys in the age of 15 or 12 up to 15, they develop some kind of masses in their breast that there is some discharge sometimes, but they usually disappear after some time. What about that?
Icyo ngicyo, so thank you for that. Ni ikibazo cya yageze muri puberty. So navuga ngo umubiri utarensitara neza ibijyanye na hormones. So it is just an issue of hormones. So nibwo abatangiye puberty, hari testosterone biri gukorwa. Testosterone murabizi ko nubwo ikorwa hari hazamo na za progesterone. So bivuga ko aramutse agize progesterone nyinshi muri icyo gihe ashobora kugira milk production. Niyo mpamvu yita bikira, kubera ko umubiri nawo uba uciye wadabuta za quantity of the hormones. So otherwise wenda ikindi ntavuze nk'uko bibaje abagabo cyangwa abahungu nabo bagira izindi masses, so bashobora kugira za fibroadenoma. So akenshi afite ikibyimba which is benign ni one breast, it is fibroadenoma, and when it is bilateral tubyita gynecomastia. So gynecomastia ni ukuvuga umuhungu wagize amabere nk'ayo umukobwa amanini. So cyegero haba habyimbye hombi, baraza nabo bajya baza ku bitaro, ugasanga benshi kuri histology gynecomastia and the fibroadenoma, it looks like the same on histology, but clinically it will be different. Because the gynecomastia, it is not well delimited, no capsule. While fibroadenoma will have a capsule, usually unilateral, so mobile mass. While gynecomastia uzabona ko amabere yombi abyimbye gusa ari manini, so ntabwo nabivuze. Otherwise ibyo byaba bigeraho bikadisappearinga akagira milk production, it is an issue for hormones. Any other questions? Okay, so we can have a 15-minute break.